Welcome to Season 4 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Commissioner of Health in Baltimore City. Our goal is to bring scientific evidence and experience to current topics in public health through engaging interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith Rogers, the producer of Public Health on Call. Today, I'm talking with Eleanor Cleghorn, PhD, the author of the book Unwell Women: Misdiagnosis and Myth in a Man-Made World. We talk about how misogyny and mythology were baked into classical medicine, how some of these biases remain today, and what needs to be done to create a more equitable health system for all people. Let's listen. Eleanor Cleghorn, PhD, thank you so much for joining me today. This book, Unwell Women: Misdiagnosis and Myth in a Man-Made World, is very ambitious. It starts in ancient Greece. It takes us through the Dark Ages in Europe, talks about global advances in medicine through the late 19th century, women's suffrage, the world wars, all the way up to COVID-19. So what has been a recurring theme throughout all of this history?
Thank you so much for having me, by the way. It's lovely to be here. I think a recurring theme throughout all of this history has been that medicine has always been a system of knowledge and power that throughout the centuries since its inception in ancient Greece has also operated to enforce, reflect, and justify gender roles in society and perceptions of what women's bodies were for, how women should live, what women should do with their bodies. It's been very much as social and cultural as it's developed into being scientific. And I think that even now, as we hope we're now in a period in medical history in which our medicine is primarily evidence-based and objective. What we're seeing is that even though medical practice and culture has shifted scientifically, that we've inherited these biases around gender that are really ingrained into medical ideas about the way that different illnesses and diseases manifest across female and male bodies, but also in terms of what it means to be a woman, what it means to be a man in society. The way that those ideas have really influenced medical ideas is sort of impressed into medical knowledge, and it's articulated today in the form of the unconscious and implicit gender biases that we're sort of reckoning with in medical treatment and practice today.
So let's go back and talk about some of these biases. Take us back to 1400s, 1500s in Europe. What did that look like at that time?
Well, we are in a period of history in which medical knowledge is primarily owned by the church. So medical knowledge is very sanctioned and very protected and very owned by men who were also owned and protected the right to create and make knowledge about the world and about humans and about how to live in the world. And so what we really have then in the Middle Ages is the classical foundational texts from ancient Greece that survived the fall of Rome. So these are texts like the Hippocratic Corpus, which is this huge collection of tracts on human health, illness, and disease and the healing thereof that are translated and have been transmitted across the centuries and translated in light of new religious and theological ideas, well, in fact, mythologies about women. And of course, one of the foundational myths in Christianity being the fall of Eve. And so what we have there is knowledge about women's bodies, which was primarily around their reproductive bodies, infused with a new sort of oppressive and really quite misogynistic mythology that women's biology was inherently corrupting and poisonous and defiling. So, of course, from there, you get some very strange fantasies and fears projected onto women's bodily processes. So one process in particular being menstruation, which was really vilified in that period in history as a defiling, poisonous, dirty process that really marked women out as being, too bloody, too fleshy, too close to the earth, too easy to corrupt. And so we can see how these medical ideas about women's bodies being very dangerous and being defective and being easily corruptible, we can see how those ideas played into a culture of fear, a climate of fear and intense suspicion around female bodies.
Tell us more about how women's health was approached at this time.
What's interesting is that women's bodies for many centuries were seen as primarily reproductive. And so many of women's diseases and illnesses really pivoted around the uterus as being almost the central organ of a woman's body, or at least the organ that was the most responsible for most of her ill health and illnesses. And so, we've all heard, I think, about the mythology of the wandering womb, which is an idea or a diagnosis that came from classical times, that if a woman's uterus, her womb, was not performing its social duty of conceiving or carrying a child, that it sort of hungered for these states, these kind of fertile and fecund states, and almost went roaming around the body in search of moisture. And as it went meandering, it could kind of press up against the heart, up against the liver, and cause all manner of symptoms, virtually any symptom you could attribute to a body the wandering womb was thought to cause. Now, of course, this idea, this really foundational idea, persisted. And so although we had anatomical ideas came through from practitioners of medicine, like famously Galen from the Roman era, had done some anatomy and proven that the womb could not move on its own. What you have is that there's already centuries of sort of mythology imbued around the uterus that it's somehow unruly, untamable, unpredictable, and pathological. And so cures for the pathologies of the womb, the ultimate cure was marital sex and pregnancy to achieve this perfect and idealized state of health for a female body, which also, of course, happened to be, socially speaking, or under patriarchy, the healthiest social state for women to occupy. So you have marital sex and pregnancy being the number one. And then after that, there were theories that, the womb was attracted to certain different smells. So things like fumigations made of all sorts of strange substances, from, crushed bed bugs to charred deer horns, would be kind of wafted under a woman's nose. And the idea being that her womb would kind of be attracted or repelled by these smells and would kind of go back into its rightful place. So, the cures really range from the completely absurd, at least by our contemporary ears and eyes, to the much more sort of sinister, in a sense, that, this sense that if a woman isn't doing what a woman is supposed to do, then she is unhealthy, which obviously opens the door to all sorts of presumed pathologies of the female body that are attached to a lack of social obedience.
And I want to jump ahead here and talk about the first sort of real research about menstruation, which didn't come until the 1870s. So tell us about that.
Medical practitioners and writers have been really interested in nerves and spirits and emotions since the 18th century. But by the 19th century, of course, medicine is becoming more scientifically minded. And theories about menstruation that used to range from, it was triggered by intercourse, it was something that, it was triggered by the penis, all these sorts of theories, because nobody really understood the physiology. So by the end of the 19th century, or the late 19th century, you have this theory called the reflex theory of ovulation, where physicians were beginning to understand that there was a physiological trigger that happened in the ovaries that was kind of prompting menstruation to happen. Now, of course, they're not quite there, but medical science is getting there. They're beginning to understand the role of ovulation in pregnancy, for example. But of course, associating the ovaries with the nervous system in this way means that the ovaries at that time were then subject to a whole new set of pathological ideas about the influence of that organ on not just a woman's body and illnesses, but also on her temperament and behavior. So it's not difficult to see how from late 19th century ideas that the ovaries would get, overly excited if a young woman dared to go horse riding or read too much or, played instruments or got overexcited. You can see how this idea is being laid down that menstruation and ovulation drive women crazy. I mean, it really made sense to a lot of these late 19th century doctors, so Victorian doctors and gynecologists. The ovaries were a really fundamental organ in terms of establishing femaleness and femininity. And that in many ways, the ovaries had sort of replaced the uterus, which for centuries had been the epicenter of women's fertile and sort of pathological bodies. And then from when the physiology of menstruation is better understood, then we see this kind of movement over towards the ovaries as this epicenter of, both illness and sort of disordered temperament in women.
Today, we have quite a few diagnoses that are still sort of tied to the idea of ovaries and reproduction. So maybe we haven't come that far. Can you talk about the state of this now?
Of course. I always think that the perfect example of how little progress we have made culturally in terms of some of our attitudes, especially to women's gynecological health, is endometriosis, which is a very complex, all-body chronic condition that affects 1 in 10, people with female bodies, female organs, and is a major cause of infertility. But it's also massively misunderstood, woefully undertreated, and it can take up to 10 years in the US and the UK to be conclusively diagnosed. And endometriosis has many different symptoms, but it will often start with menstrual health related symptoms. That might be menstrual pain or very heavy bleeding. Now, endometriosis as a distinct disease was named in the 1920s, but the symptoms of menstrual ill health and gynecological ill health have, of course, been documented since the classical era of medicine. When we see something like endometriosis being documented by gynecologists at a time when the theories of menstruation were better understood, when they understood how this endometrial similar tissue was growing in the body, we also see this hangover of the idea that, gynecological pain, menstrual pain, and heavy menstrual bleeding are sort of signifiers of a hysteric or overly emotional or irrational female nature. And in the 1940s, when there was more extensive research done into endometriosis, there was an awful lot of focus on who got it and what kinds of women got it. And from there, because it happened to be being studied by a gynecologist who worked in private practice in the States, he believed that endometriosis was a disease primarily of young, affluent, white women, and that it was caused by women delaying childbearing because they were choosing, to pursue careers or go to work. And of course, we're just on the back of a global depression then. And this was actually enabling more women in the UK and the US to go to work through necessity, but also there's a sense of a kind of freeing up a little bit of work-related roles. So it doesn't seem to be too much of a coincidence that, claiming that a disease like endometriosis was caused by ambition and work and sort of abandoning the biological imperative. So it became almost a sort of punishment diagnosis. And the cure, the supposed cure anyway, then, as well as something like ovariotomy, removing the ovaries, hysterectomy, removing the uterus, was childbearing. Women were recommended that they procreate vigorously and often, to quote a gynecologist called Joseph Meigs. And still today, we have a global health crisis around endometriosis. And still, we're seeing that patients with this disease it's being recommended that they, get on with having a baby, that they might think about having a hysterectomy, both of which have been shown not to be cures for endometriosis. But this shows us just how much sticking power these kind of misogynistic mythologies around the association between women's social behavior and women's illness really is. And it's like until we really face up to those mythologies and the damage that they have done, we can't sort of see these diseases clearly enough and really account for the blind spots in knowledge
Another theme of your book is equity. Throughout history, women of privilege have suffered, but perhaps less so than those of color or lower socioeconomic standing. What are some lasting legacies that you've seen there in your research?
I think that, it's always really worth remembering that, at least up until the 19th century, that medicine was an elite profession practiced by men. And men own this knowledge, but not just any men, elite men who had money, men who had social standing. And in order to see a physician, a private physician at least, a woman had to be also of a certain social standing in order to be able to afford it, or for her family to be able to afford this. And so what you have then is a very skewed set of knowledge around women's illnesses. I mean, it's often said that hysteria, which of course is a famous diagnostic category for many unexplained diseases of women's bodies and minds from about the 17th to the sort of early 20th century, we often see that this is applied to women of certain social standing, so middle class, upper class women who have leisurely lifestyles, who have too much time to think about their bodies and ruminate on their every sensation. Whereas, working class women, ethnically diverse women, poorer women are exempted from these narratives. So what we have, of course, is a pathologizing of a certain kind of womanhood. But we also have an ignorance and almost a contempt for women who, did not fit into that sort of, doctor-patient social dynamic. So you get a lot of theories, coming up, especially in the earlier 19th century, about things like spectrums of pain. So spectrums of pain sensitivity across different people. And there was a theory around this time that was linked in with anthropology, which was about how much sensation and feeling a person was capable of, depending on how, and I use quote marks here, civil they were. The most civilized people were those who are enjoying the spoils of colonial wealth. So we're talking about, Western European, white people who had access to things like coffee and sugar and chocolate, and they had leisure time. And then the other side end of this pain scale were essentially enslaved people. So Black people, ethnically diverse people who were, it was claimed, were less vulnerable to pain and sometimes even invulnerable to pain. And what we see from this completely racist misbelief, something that was really perpetuated to justify some of the crimes of slavery, is we see a persistent racist bias that Black people, and especially Black women, don't feel as much pain as white women. So as a white woman, I may risk being called anxious or fussy or emotional, or even in insinuation of hysterical if I complain about pain. But a Black or ethnically diverse woman might have to really struggle against a bias that would claim that she is not capable of feeling that pain at all. So what we have is this really skewed system of values around whose pain we prioritize, whose pain we see as more deserving of attention, of understanding, of compassion and empathy. And I mean, there's been racial bias studies done intersecting with gender bias as late as 2016 that show that these biases around the pain of people of color are still present in medical training, in medical practice. And so again, we have to really work not just to acknowledge that the biases exist, but to really understand where they came from and why they have persisted. And, to really examine closely the consequences of these persistent biases that have, again, come from unchecked power. And I feel that the one around Black women's pain is really, where we see some of the most sort of dire consequences of this persistent bias is, of course, in maternal mortality and morbidity. And the UK and the US, of all the industrialized nations, have the worst record of maternal mortality and morbidity, especially for women of color. And a lot of this is attributed not only to a sort of a failure to recognize or legitimize the pain of Black women, but also to kind of deny Black women the agency and intuition around body knowledge, around knowing what's happening in their bodies, around being able to articulate what's happening in their bodies. So I think women come off pretty badly in terms of the sort of body autonomy and being seen as reliable narrators. But again, depending on these intersecting biases, you are privileged as someone who can speak for their own body, or you're completely ignored.
The very last line of your book paraphrases Maya Angelou and the quote, "When a woman tells you she is in pain, believe her the first time," which is a really nice way to sort of sum up thousands of years of history. What do you think needs to happen in order for this to be heard?
I think that two major sort of shifts need to come about. And one of course, is systemic. Medicine is a system that, in order to kind of create knowledge and have that knowledge filter down to our caregivers, our everyday caregivers, our GPs, our hospital doctors, we need for not just these biases to be understood, but also for the kinds of diseases and illnesses that have been undervalued and deprioritized over the centuries to now become the shift and focus of medical progress going forward. And also, we have existed within a very strict kind of binary around sex and gender difference in terms of medical research and in terms of clinical progress for some time now. And it feels like, what we need to do in order to understand not just how disease and illness manifests in different human beings, but also what it means as, a woman of color, as a non-binary person. What does it mean in order to navigate your own health? What do you have to do in order to achieve good health? If there's a diversification, however, at all levels of medical practice, then I think we can really look forward to a more equitable health culture for women and for everyone.
Eleanor Cleghorn, thank you so much for joining me today.
Thank you so much for having me. It was such a pleasure.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo and Neiman Outland. Social media support from Brenda Haggader, Grace Holes Fernandez, and Caroline Wong. Thank you for listening.